Hi, good evening guys. So tonight's talk is all about frozen shoulders, and the four things I'm going to look at is firstly what causes a frozen shoulder, the risk factors for it, which leads nicely on to whether we can actually avoid it or not, and then lastly we're going to look at all the different treatment approaches and how we approach it in the clinic I work in. For you guys who don't know me, my name is Maryke. I'm the physiotherapist from sportsinjuryphysio.com, where you can get online physiotherapy consultations and treatment via video call. Now, let's jump right in. The first thing I want to say about frozen shoulders, it's also known as adhesive capsulitis. That's the medical term for it. Whenever you read a blog about it, or even in the research studies, they always say that it's a self-limiting condition that fully resolves within 2 years. Now that is absolute nonsense. It doesn't resolve by itself fully after 2 years. You have to work really hard at it. And if you look at the studies that followed patients up for 5 to 10 years after they were initially diagnosed, a large percentage of those people still have limited range of movement, and some of them still have pain. So if you want to get your full range of movement back and your full strength back, you have to work at it. But that's that said. Now, what causes a frozen shoulder? Let me just get my slide up. In short, the researchers aren't quite clear what sets it off, but it's an autoimmune reaction, which means it's your own immune system that becomes overactive and attacks your shoulder joint. It's mainly the capsule and the ligaments around the shoulder joint that becomes really inflamed and painful. And this inflammation causes thickening of the capsule and the ligaments, it causes adhesions, and it causes fibrosis, so scar tissue in there, and all of that makes the capsule and everything contract, and that narrows the joint space. So the natural kind of progression of a frozen shoulder is that it goes through a really painful stage while it's actively inflamed. Initially in that painful stage, you have quite a lot of range of movement, except nobody actually wants to move it in that stage because it's so painful. But then it becomes dramatically tight. And I find with my patients that it's mostly the external rotation, so turning the arm out, as well as trying to put it behind their backs. They can basically not do those two movements. They usually have about 70 to 90 degrees flexion if it's really frozen, and less in abduction. But yes, if it's a proper frozen shoulder, then external rotation especially is quite dramatically limited. The one thing I would say about that is don't confuse any really painful shoulder with a frozen shoulder. Okay, for a frozen shoulder to be a frozen shoulder, the range of movement needs to be quite limited as well. You get several other types of injuries like rotator cuff tears and things like that that can cause just as much pain, but that pain settles quite quickly with treatment, whereas a frozen shoulders is excessively painful and it doesn't really react to normal pain medication and things. You get primary frozen shoulder, which basically develops for no known cause. It just starts, and it usually starts with a bit of a niggle and then progressively becomes more and more painful, and that can happen over a couple of days, or it can happen over several weeks that it develops into a full painful frozen shoulder. But then you also get secondary frozen shoulder, which is in reaction to an injury or a trauma of some sorts. So it can be that you had a rotator cuff tear, or you fell on your shoulder, or you even sometimes after a fracture, that kind of initially is the thing that's injured. And I've seen patients like that I go, oh, okay, you've got a rotator cuff tear. And then 2 weeks later, I'm going, this is not acting like a rotator cuff tear now. The pain is way too intense. We're not getting better. We're getting worse. And the things that I'm thinking should work is not working. And then when I send them to the doc for further investigation, it turns out that they've also now got a frozen shoulder on top of the original injury. So what are the risk factors that can cause, or that they know can lead on to this type of thing? So we don't know quite why the body creates this overly inflamed shoulder joint, but some of the things that seems to be risk factors is women tend to get it more than men, and usually between the ages of 40 to 60 years old. Now, I looked at the research today because I thought you know what, that age bracket fits in very well with when the menopause starts. But I've really tried to look and I couldn't find any research that links it to the menopause. So it may just be something that's not researched yet, or it may just be coincidence that it's that bracket of women who gets it more. Then if you've got other autoimmune diseases like rheumatoid arthritis, I can't remember any of the others now, but anything that's classed as an autoimmune disease, irritable bowel, things like that, some of those things can also count to that. Then you may be predisposed to that. And it may not be that you've got active rheumatoid arthritis. It's sometimes if somebody else in the family has that, you may have a genetic predisposition to frozen shoulder. Diabetes is a massive risk factor. Diabetes causes can cause trouble in all of your ligaments, all of your joints, because it increases the chronic inflammation in the body in any case. And in patients who have diabetes and then gets a frozen shoulder, their recovery is never as good as somebody without diabetes. So there's another good reason why you should really be controlling your blood sugar levels. Extremely high cholesterol. Now, I'm not talking about cholesterol level of like a 6 or a 7. We're talking about people who have pathological levels, so 9 and above, so really, really high levels for a long period of time. That can affect tendons as well, so that's quite a common cause for Achilles tendinopathies and things in those people as well then. But that can predispose you to frozen shoulders. Thyroid disease, so overactive or underactive thyroid, can cause trouble there. And then also what they found is strokes. So if somebody's had a stroke, they can sometimes develop a frozen shoulder after that. Again, they're not quite sure why that happens, but something in that process triggers that inflammatory reaction then. Which leads us on to, is it possible to avoid frozen shoulders? So if we look at that list of cause or risk factors again, there are a few things in there that one can say is lifestyle related as well. So we know for autoimmune conditions, they definitely get worse if you're very stressed or you don't eat a good diet or you don't get enough sleep. So things like that is important for your general health in any case. Diabetes, you can avoid type 2 diabetes through a healthy lifestyle, enough exercise, following a good diet. Very high cholesterol, you can be on medications to help that, or again, if you don't have the genetic form, you can get that right through good diet and exercise. Thyroid disease, you can go on medication for that. I don't know if it still predisposes you to it if you are medicated thyroid disease. Not sure about that. And then with regards to strokes, we know that a certain number of strokes can be avoided through healthy lifestyles. So I guess this is kind of a roundabout way of saying you can avoid it, because we'll never be able to do research to show that you can avoid it through that. But if we look at the risk factors, there's definitely a lot of lifestyle changes you can make to mitigate your risk of getting a frozen shoulder. Now, that takes me on to treatment. Let me just see if I've left anything out so far. No, I think that's everything so far. So remember, guys, if you've got any questions, you're welcome to ask them in the comments. And if you're watching this on replay, make sure you ask them and tag me, especially if you're on Facebook, because then I'll answer them for you again. So when we look at treatment, we've got the two specific phases. We've got the painful phase and we've got the stiff phase. Now, that painful phase is thought to be caused by that extreme inflammatory reaction. And your treatment during that phase is very different from when it's just the stiffness, where the pain is under control, but it's predominantly stiff. What I find during the painful phase, people tend to have very interrupted sleep because they can't get comfortable. They often, even just driving a car where they bump, that can hurt. They tend to not want to move that arm much because it's so excruciatingly painful. Now, most of my patients find very little relief at that point from regular pain medications like ibuprofen or paracetamol or things like that. Some find relief from anti-inflammatories, but it really doesn't really take the edge off usually. Massage and dry needling, that type of stuff, if I do that for them, it gives them a tiny bit of pain relief, but to be honest, the pain returns pretty much nearly immediately. And that makes sense because the pain's being driven by this massive inflammatory reaction. in the capsule and synovium of the joint. So the best thing that we find in clinic that works to calm that inflammation and that pain down, and it's backed up by the research, is a corticosteroid injection. And this is probably one of the only times that I will say go for a corticosteroid injection as quickly as you can. But make very sure that it is a frozen shoulder and not a rotator cuff tear or something like that, because you don't want to stick cortisone into an area where something is torn, because then you can actually limit the healing process. With this condition, we don't have any injury there. We've got just massive inflammatory reaction, and we need to calm that down. And what we find in clinic is if we can do a cortisone injection into the shoulder joint. So what the research also shows is that injections into the actual joint rather than into the subacromial space works a lot better and is more effective. Now, if a person with a frozen shoulder in that very painful stage can get a corticosteroid injection quite quickly under ultrasound guidance, so I usually send them to the sports docs for that, it can dramatically decrease their pain. And also, because you're limiting that inflammatory reaction, you limit how much scar tissue and fibrosis forms. So they usually don't lose as much range of movement. So their rehab period is a lot shorter than somebody who's had it for months and months and months. So that is, if I start to suspect a frozen shoulder in a painful stage, I send them off to the sports doc immediately they usually scan them to make sure there's nothing torn. With ultrasound scanning, and then they'll proceed with whatever injection they think is suitable. Because I'll mention another type in a minute, which they sometimes combine with cortisone that can work really well. With regards to exercises during this stage, please don't try and do strong stretches to get range of movement there. It will just make the pain worse. What I find most effective during this time is just keep it moving, and the pendulum exercise is really useful for that. So let me demonstrate that one quickly before I forget. So when you do the pendulum, it's important that you use gravity to do the movement. So it's a very loose movement. Now you'll notice I've got my one arm on a chair, and usually it works best if you have something that doesn't move around like this. So table or something like that can work well, because I don't want you losing your balance, and I want you to concentrate on really just relaxing it. And all you do is you gently let the arm swing forwards and backwards. You can also swing it side to side very gently, but I want to show you my side to side movement is really tiny. Okay, I'm not going as far as I can, and I'm not trying to force it. And the same with forwards and backwards. I'm not trying to force it using my muscles. I'm literally nearly trying to use my body to just swing it forwards and backwards. And what this does, if you can do this for about a minute or so, you'll find that it can actually help to calm the pain down as well. And if you can manage to do that regularly while you're in the painful stage without causing too much increase in your pain, you will again limit how stiff that shoulder gets. So it is an important part of your rehab, but you've got to make sure that you do it gently. Okay, it's not about how rough you can go, and it is definitely about can you do it for at least a minute, because then you'll see better effect. And then it's not just a once a day thing. If you can do it 3 to 4 times a day, little bits often tends to work really well with this. So yes, during this painful stage where you're still not sleeping well and things like that, that's basically the exercise I get my patients to do during that stage. Did I leave anything out? No. So now we enter the more calmer stage where pain's concerned. So the whole time that inflammatory reaction is going, that shoulder joint now stiffens up. And depending on how badly it stiffens up, you may find that you have extremely little movement outwards, can't really get it behind, you can't even get it onto your bottom, and definitely when you try to lift it, there's nearly no lift to the side or forwards. So during this stage, you do get some pain, but it's usually when you move it into the restricted part. So when you just move it in the easy bit, it doesn't tend to be that painful. It's only when you get to the restrictions. But it's really restricted in range of movement. So we have to start doing exercise during this stage. You may also find that your neck becomes really stiff on the side that's affected because the neck muscles all attach around the shoulder, and if you're not able to use the shoulder properly, you can end up with a stiff and tight neck and soreness all over here. So during this stage, I do find massage as well as dry needling extremely useful to help with that extra pain that shouldn't be there. So the stiff muscles, the muscle spasm, all of that. And just getting rid of the muscle spasm can often give my patients a few more degrees of range of movement as well. Joint mobilization, so where you stand and mobs the joint for patients. Again, it can be quite useful for pain relief. I find in practice it does provide a tiny bit increase in range of movement, but to be honest, I gain that same range just through doing the soft tissue work. So I like to go more towards the soft tissue stuff, but there is evidence that the joint mobs also work. What I will say is I don't believe in doing painful joint mobs or painful stretches and forcing my patients' arms into positions that's really uncomfortable for them. And that's for two reasons. One, I used to do it, but what I found was that it's quite traumatic for the patient. So it's not a nice thing. So they tighten up more, and it's just an all-round not good experience for them. Second, I don't make that much gains in one session. And if they don't do their exercises until the next session, that the gains we made does not actually remain. So then I thought, okay, how about I just get them, that they do the exercises to a point where they want to hurt themselves, but they have to do it very regularly. And what I found is that I get the same amount of increase in range of movement within the session, and then they actually keep that, plus they gain range before I see them again. So what I do is, first step is I make extremely certain that they understand that that shoulder will not move if they don't make it move. Okay. The second thing is they have to understand that they have to take the stretch exercises I give them to where it's strongly uncomfortable, but not so painful that they want to cry. Okay. When they take it out of those positions, the pain should settle within a few seconds of them saying, oh, sorry, I didn't quite mean to kill you off. Okay, so just moving it. And what I don't want to see is that their night pain starts to become more uncomfortable again, because that means that we're too aggressive with it. We can't have it that the pain's affecting their sleep, because then we've got them back into inflammatory stage. So they've got to be strong stretches, strongly uncomfortable, held for at least 30 seconds, but if they can hold it for longer, that's better. And they've got to repeat it 3 or 4 times in one go. And then that little set of exercises, they've got to do 3 to 4 times a day. So I find that approach of not quite killing yourself, but being strong with yourself several times a day works much better than me doing a hard, painful, upsetting session once a week. Let me just think about the exercises if I've said yes, and I'll demonstrate some of the exercises I give in a minute for you. Actually, let me show them quickly to you in any case. So if we think of stretches that we start with, this is not rocket science. I tend to stick with very simple things because, to be honest, if somebody's got to do that many exercises in a day or move it that often, it does kind of take your life up. So I try to keep it to 4 exercises max that they've got to do. And if I give them more, then I say you don't do them all in one session, you break them up. Okay, so they may do, say, these 4 this morning, these 4 middle of the day, middle of the afternoon, and then evening other 4. Okay, so the first direction we start working on is this one, because that is always the most restricted one. You've got a few options. One of the easiest things is, while they're sitting in a chair, if they find themselves sitting anywhere, they just do this movement. They try and do this as much as they can during the day. Now, this is not a stretch. I know this is just a passive movement, but you'll be surprised if they can get into the habit of just trying to do that to where they feel they're restricted, basically the whole time they sit and watch TV, how that can improve things. Now, I do like a stick for this time as well. And what I find useful is if you can use the stick to help your arm turn out. I'm going to use this hand because it's more visible. So imagine this is my stiff hand. Okay, this is my good hand. Let me move over This is my good hand. So I'm using my good hand to help push my other arm out. And I push it to where it feels a strong stretch around this area. And that's why I keep it. Now I'm not pushing back with this one. I'm allowing it to being pushed and helping it to be pushed to its full range. It works really well if you can have your back against a wall or a chair or something, because otherwise what you tend to do is you tend to move your body because it's not a comfortable stretch. So you want to rotate the arm out using this hand to push that one over. Okay. And remember, you're holding it for at least 30 seconds. Bring it back, move it a bit, okay, and do it several times. Or you can also just sit for a few minutes and help push it as far as it can go to that side. So that's for external rotation. And the reason that's important is you can only fully bring your arm up to the side if your arm can go into external rotation. You can try this. If your arm is only able to be in this position and you try to lift it, that's as high as I can lift my arm. And it's because you've got two knobbly bits on your bone that has to rotate out from under this bone, otherwise it's blocked. The two bones block each other. But as soon as I turn my arm up like this, I can actually lift it all the way up. So palm up, arm can lift, palm down, arm gets stuck. And that's why you need that range of movement. Now the second one that's quite important, and people hate this one, is trying to get it, sorry, this camera confuses me, trying to get it that it comes up your back. Okay, so test this. See what your good arm can do, and then that, you know, is where you're reaching for eventually. But don't worry, if you've got a really stiff shoulder, it won't even reach there. It will likely only reach there. Now, that movement is made up of 3 movements actually. The first is just extension, okay, so taking it straight back. The second part of the movement is crossing over, and then the third part is coming up. So don't try and come up immediately. What you first can do, if you're really, really tight, is just work on getting it back. And a good stretch for that is if you grab hold of a table and then step forwards that the arm stays there, and you get a nice stretch into extension. Now once you feel you've got that under control, then you can start by just seeing if you can ease that hand across your bottom, and you can use your good hand to pull it over. Okay, and again you take it to where it feels strongly uncomfortable, and that is an uncomfortable stretch, and you hold it there, and you try to hold it for at least 30 seconds. But then if you take it out, if you swing it a bit, that pain will dissipate. Okay, it will go away. And then you repeat it again. If you struggle to reach that arm with the other one, if it's too tight, again, you can use a stick. Walking stick works really well. And all you do then is you just pull it across the body that you can get it there. Now, this is another stretch that you can do anywhere you are. So if you find yourself waiting in a queue, if you find yourself waiting for somebody, kettle to boil, something like that, just stand with that arm where it's uncomfortable behind you. Okay, so what I'm doing is this. I'm just pulling it to where it feels uncomfortable so that you constantly get it to try and be in that position. That's how you will get that range back again. Once it's comfortable coming over, then you can work on getting it up. Okay, so once it's comfortable to come over to the opposite buttock, then you can work on trying to get it up. And that takes several weeks. It's not a quick thing to come, but you want to see week on week little improvements. So make sure you document it. Maybe take a picture of yourself in the mirror or something like that. So that kind of sorts out the rotations for us. Now the next one is coming up with the arm. And nothing beats the old wall crawl. To be honest, actually, I'm going to correct myself there. You could do it in lying down as well. So if you can imagine I'm lying on a bed, okay? I'm sleeping. You could use your one arm, take it up with the other arm to try and get it behind your head that you can eventually get it flat. That's a good one because you can stay in that position for a while. But otherwise, if you face the wall, and I usually use, let me just see that I'm in the picture. I usually test it with my good arm first, see how far I can get my good arm up. And that's my mark that I know I'm reaching for. And then I try to take my other arm, but you may have to climb up the wall with your fingers to where you can. And if you get to where it feels really uncomfortable, that's where you hold it. And you breathe while you're holding it. You try and hold it for at least 30 seconds again. If it's too much at the beginning, you hold it for 10 seconds, whatever you can do. If you hold it for shorter, just do more repetitions. We want to get to a total of 2 minutes for each of these stretches every time you do it. Okay. And make sure you mark where you can get to week on week, because again, that's a really good motivation when you can see that you're getting better at it. The last one I usually add in for range of movement, and I don't necessarily give this on the first go because I like people to start working on the other ones first, is to get it to lift out to the side. And for that, I definitely use a stick at the beginning. So I get them to hook. Which shoulder shall I show? So let's pretend this is my painful or my frozen one. You hook your thumb over the tip of the stick so that you can use your other hand to push that arm up. Okay. So you're pushing it up as high as you can, and then you try to hold it there. Okay. And again, we're aiming for 30 seconds, but if it's too much, you can bring it down before that and just swing it a little bit and repeat that. Okay. So none of these sets and reps are set in stone. Just know that the more you can do it and the more often you can do it, the better results you're going to see. But you don't want to cause pain that lasts for more than a few minutes after, and you do not want to stir your night pain up. Okay. So that's flexibility exercises for a frozen shoulder. But it's not all that you've got to do. So a shoulder that can have range of movement to move is great, but you also need muscle strength. So you need to strengthen your shoulder up as well. So TheraBands can be quite good. You want to do external rotation, pulling it out, pulling it in, pulling it up. You can do hand weights. You can, as soon as you've got enough range and it's calm enough, you can actually go into the gym because you can do any of the machines that you pull towards you. You can push away with the cables at this level. You can probably not do the pulling down, but you can set up the cable machine that you can pull down in the range you've got, and then with the cable going up can give you really good range of movement at the top of that. So yes, any strengthening exercises you want to do, as long as you do them very light at the beginning, build up. Remember, those muscles are all in shock, so I would start with isolated rotator cuff work with TheraBands and stuff first, or very light weights. And again, it should be done pretty much pain-free and shouldn't stir up your pain later. Often I also find if we reach a little bit of a plateau that the range of movement just doesn't want to increase. If we can really work on the strengthening, then that gets us more range of movement again. So I start with the strength training long before I've got full range of movement in the shoulder. Now, even if you do your exercises really well and you're really diligent with them, you may hit a point where it just does not want to budge. And in those cases, or at that point, I usually refer my patients back to the sports doc, because there's another type of injection that they can do. And they often combine it with a little bit of cortisone again, which can really make a big difference. And this injection is a hydrodistension injection. And it's exactly what the name says. So what they do is they take a lot of clear fluid, just sterile water, and they inject that inside the capsule of the shoulder. Now remember, this capsule is all contracted. It's got adhesions that's stopping it from expanding, and that's the reason why this shoulder can't move. So what they do is they push all of this fluid in there. Some people use air, and it literally just stretches the shoulder capsule. And usually these patients get an immediate improvement in range of movement because it just breaks those adhesions that we couldn't break through the exercise, and then they can get going again. And because they combine it with the cortisone, it doesn't create that massive inflammatory response again. So it's not really a painful injection to have either. Often I find then, yes, that gives us what we need to be able to crack on with the exercises again. In the olden days, they were really in favor of manipulations under anesthetic, basically where they put you out under anesthetic and they just yank your shoulder to get the range of movement. Luckily, that is starting to fall out of favor, because actually with that, you can think, if you yank the shoulder, it's not a very controlled thing. So what they found was that they were actually causing labral tears, they were causing rotator cuff tears as well. Sometimes if the bones weren't very strong, they were causing fractures. So they're tending to start to say that they should rather be using the hydrodilatation injections, because what the research is showing is that you get the same result with the two. And I will say that in our clinic, I've never seen, I've worked there for 9 years now, and we've never referred a patient with a frozen shoulder for surgery, because this combination of the cortisone injections and the stretch injection for the capsule, combined with really diligent exercises from our patients, usually gets them better and gets them proper functional again. But the importance is that the patient has to understand that they have to work at it. If they're going to be lax with the exercises, it will not come back. Even if the physio does strong mobs for you, you will have to go every single day if you want that shoulder to get better. Okay, so you have to do your exercises, and you have to do them at a strong enough level. If patients follow this combined regime, I find that most of my patients get to about between 85 to 90% where they want to be within 4 to 6 months. And then they still have to keep on working at it to get the rest of their range and the rest of their function back. So I can highly recommend, if you've got a patient who has got some range back, just not that little bit, see if you can get them to see a sports doc or somebody else who does the I can never remember how to say it, the hydrodistension injections. And if you suspect this frozen shoulder and it's in that very, very painful stage, get them referred to, if it's only access to a GP they've got, some GPs even does the shoulder injections and things these days. So get them referred for cortisone injection as soon as you can, but make sure that it's the right diagnosis. Excellent. So that's basically my story for today. Remember, if you need any help with any injuries, you're welcome to consult me via Skype or via video call as well. It works quite well because I can see you move, and we can do a full-on assessment like I would do in clinic. And yeah, I can work out a treatment plan for you. Let me know if you've got any questions. Take care.